You are listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
In today's episode, Dr. Michael Ayers and Dr. Robin Bride explore the challenges of managing comorbid conditions in patients with hypertrophic cardiomyopathy. What makes these seemingly straightforward issues, like hypertension and sleep apnea, particularly challenging in HCM patients? Join Dr. Ayers and Dr. Bride as they discuss the complexities of treating common comorbidities such as obesity and type 2 diabetes in the context of HCM, and how factors like obstructive physiology can affect treatment options. They also share practical insights into surgical clearance and the careful considerations needed to optimize patient outcomes. Let's get in the thick of it. Here's Dr. Michael Ayers and Dr. Robin Bride.
So, Dr. Ayers, starting off with probably our biggest comorbidity that we deal with is managing high blood pressure in this patient population. Do you mind kind of walking us through how you approach this? Of course, it's probably going to be different for obstructive versus non-obstructive patients.
Absolutely. Before I do that, I'll say, despite the fact that these are really bread and butter cardiology topics, it's actually exceedingly difficult to find time, place, space to address these things. For those of us who take care of HCM, these visits can be really full. There's often family members, we're dealing with genetics, we're dealing with possible surgeries, we're talking about cardiac myosin inhibitors, we're talking about screening algorithms, right? And many providers have extended these visits. So you would think to yourself, it should be pretty straightforward to tack on these other things. But I will find very often I am struck that I didn't address some of these things in a first or even sometimes a second visit because these visits are so full. So I do think it's a very important topic and a very important thing for us to address. And despite the fact that it might seem straightforward, gosh, sometimes it's hard to fit it in.
You are so correct about that, because sometimes I'll be finishing a note and I'm going, I didn't get to address this. I could do better here. I could do better there. So I make little notes at the end to follow up on certain issues. So very good point, because you're probably using every bit of an hour with these visits.
Absolutely. Our new visits, our initial visits are an hour. And I have some of my general cardiology colleagues go, how are you doing an hour? Like, what do you talk about? Man, we find things to fill that space and then some. Your question was about hypertension. So hypertension is actually really tough. And the first thing that's probably the most important when we're addressing hypertension is one of the things that I actually preach about all of HCM in general. And that is you have to start by correctly subclassifying your obstructed and your non-obstructed patients. If you miss this, you can do some things that really make patients feel worse, that erode trust between the patient and the provider. You got to get this right. And so I know you trained with Dr. Martinez, so I suspect I know how you're approaching these patients. But usually I'm not relying on just a surface echo with a Valsalva to make this obstructed, non-obstructed distinction. I am almost always getting some sort of an exercise data to make sure I pick up on the occult obstruction. So about a third of patients are going to be non-obstructed. About a third of patients are going to have overt obstruction. But there's that tricky third that we know about, Robin, that are so hard to elicit that obstruction, even with Valsalva. You got to make sure you get that right. And the reason I'm sort of hemming and hawing about this as the initial point is, in a non-obstructed patient, where I'm 100% confident I've correctly labeled them as non-obstructed, I have a lot of wiggle room in terms of what agent I want to start. In general, what I'm starting with is based on what the patient's telling me. If the patient's telling me they've got exertional chest tightness, I'm usually using something with an anti-anginal property like a beta blocker or a calcium channel blocker. If the patient has symptoms of volume overload, I'm typically starting with the diuretic. And if the patient doesn't have either of those, I'm actually using a lot of valsartan based off the Vanish HCM data, which suggested some disease modification that I suspect is not specific to valsartan, but that's the agent used in the trial. I'll add to that, though, Robin, I have a low threshold to use combination up therapy. And so sometimes I'm using some combination of two of those agents, an antianginal, a diuretic, and valsartan. Now, if you're obstructed, my treatment options become much more narrowed. There are good studies that suggest vasodilators and diuretics worsen obstruction. And if you take a moment and think through the hypertension guidelines, that knocks out a lot of our agents. And so in obstructed patients, I'm starting usually with a non-selective calcium channel blocker, verapamil, diltiazem, where I think I'm getting some sort of a afterload reduction in addition to my negative inotropy. Just a little word to the wise, if you have a really bad obstruction up front, the DILT or the verapamil has, in case reports, worsened obstruction. That's pretty unusual. I don't think I've ever seen it clinically, but there's case reports about that. So again, taking a big step back and summarizing that, get obstruction, non-obstruction correct. If they're not obstructed, the world's your oyster a little bit. If they're obstructed, man, your hands are tied. You got to avoid the vasodilators and the diuretics.
So, question about that, because I do love that you first tried to correctly classify these patients, because agree 100%. That is key, because you can do a lot to make things worse if you don't correctly identify it. The patients that are most challenging are those ones that are coming in telling you, I'm completely asymptomatic. And, sometimes these patients, they've been living with these symptoms for so long, so it's really hard to identify symptoms. Because if I have a surface echo and I don't have a gradient and I don't have symptoms, I sometimes have trouble justifying the stress echo. If they're really like, no, doc, I don't have any symptoms, and it really looks more like that mitral valve's not getting anywhere near the septum, I might be more comfortable foregoing the stress echo. But I really do try to elicit those symptoms. Anything that you do to help tease out symptoms in these patients.
Absolutely. And I do say that to the patients. I say this stress echo is really doing two things for me. One, I'm going to make you worse if I don't understand obstructed, non-obstructed, just like we just discussed. But two, sometimes you live with this for 20, 30 years. You don't know what normal is anymore. It's tough for you to have a gauge. So I want to make sure that what you're reporting to me and what your echo shows and what your exercise tolerance is are all copacetic. And sometimes they are, but as you know, quite often they're not.
Yeah. Standing there when they're on the treadmill next to them and they go for 5 minutes, you're going, man, we got to do something about this, because that's going to be one of our other topics is physical inactivity. But we'll touch on that one in a minute. So I think that that was a very nice comprehensive review about hypertension. So I would love to move to the next topic, which is going to be obstructive sleep apnea in these patients. So coming into the office, how are you questioning them? Generally, these visits, you have someone accompanying the patient. So I always look to the other person too for some help in teasing this out. Tell me how you kind of go about this.
Yeah, so to be honest, this is going to be more in my second to third tier of thought process, unless they've got some red flag feature that's jumping out at me. And what are a couple of those red flag features that would make me address this up front? The one that comes to mind first is they've got uncontrolled AFib. Maybe they failed an ablation, maybe they failed 2 ablations. They're breaking through an antiarrhythmic therapy and they're miserable. The one thing that the sleep apnea trials do well across the board is they decrease rates of atrial fibrillation. And so I'm really using that as a trigger. My nurse does take a brief, essentially a modified Epworth, where she's getting some sense of sleepiness. And if that really jumps off the page, sometimes she'll tell me. And we're using that to trigger a sleep apnea workup. But I would say more likely than that is the third thing I'll mention, which is I'm having trouble controlling the blood pressure, not to go back to number 1, but I'm having trouble controlling the blood pressure in a non-obstructive patient who's starting a third line agent. Well, now I'm trying to reach back to my general cardiology grab bag of tricks and say, am I just missing sleep apnea that's driving all of this with autonomic dysregulation? And so those are the 3 things that would make me address it up front, first visit. Once I get a handle on the other things with HCM and they're coming back a second or a third time, that's where you might be doing some more broader net casting to make sure you're not missing things like sleep apnea. But I would say by and large, it's those three red flags that are really drawing me to it up front. I don't know. How are you approaching sleep apnea?
I think that weight comes into play, neck circumference, but I love the idea of having your nurse do pre-screening on this. I think that that's a fantastic way because, like you said, there's so much to cover in these visits. So any sort of pre-visit checklist, I think that that's a great idea. I might incorporate that into my clinic. It's daytime somnolence. It's the person accompanying the patient saying they're snoring, agreed blood pressure, AFib. The studies do report increased prevalence of NSVT with untreated sleep apnea. So that hasn't been my go-to, to be honest with you, is NSVT to think of sleep apnea, mostly atrial arrhythmias. So I think very similar to you, but I do love what you mentioned about getting your nurse involved and helping you streamline some of this. I think that's a great tip because this is a very busy clinic.
Absolutely.
And then, of course, atrial fibrillation in this patient population, that's a whole nother talk. But anything we can do to reduce their risk of developing AFib, because I think just like most cardiology patients, it can be a nuisance to deal with and quite difficult to get good control of. And in our patients with HCM, there's additional risks that come with it. So moving on to obesity and type 2 diabetes. This has been changing significantly due to the new GLP-1 agonists out there. And many of our patients with HCM, due to exertional symptoms, do suffer from physical inactivity, which leads to obesity, diabetes. What are you saying to patients when they come into the office asking you about these medications? Do you find that you're starting these medications, or are they coming to you saying, hey, my PCP wants to do this?
The GLP-1s just keep gaining steam in the cardiology spheres. And I'm told by some of my senior mentors that it's a lot like what statins were in the 90s. In the 90s, cardiologists didn't start statins. That was endocrinology land. We don't need to do that. But as trials just became overwhelmingly supportive that these are cardiac drugs, you had to learn to write statins. I'm seeing similar trends with some of my partners in general cardiology, where GLP-1s just have so much overwhelming benefit. It's getting harder and harder to avoid or to, punt this to your primary care provider, to your endocrinologist. So overall, what I'd say first is more and more cardiologists are writing these meds. That said, they are a new class of medications and they do require some awareness about how to start them. And I recognize that. And that might be a limiting reagent for some places. With respect to my practice, I have a pretty low threshold to start a GLP-1 agonist. Now, keep in mind, I'm very fortunate that I have an embedded pharmacist with our practice who's helping me with prior authorizations. She's helping even sometimes glance at different plans and say, this will be covered, this will be covered. So I'm getting a lot of help and I recognize that. And I don't know if I would be as eager to start these meds if I didn't have that help, but I'm starting a lot of these meds. And in whom am I starting them? Well, I'm mostly using two things, BMI and A1C. And if I see either of those flags, this is really becoming my first line agent for this class of patients, the HCM patients. There's some pretty good safety data that came out of Penn with Noshin Reza that suggested GLP-1s, by and large, even in obstructed patients, didn't seem to be worsening gradients because there is some hypothetical concern. They get nausea, they get decreased PO intake, they lose their preload, obstruction gets worse. That's not playing out by and large in the data sets, but I do advise patients about that. So sort of to summarize, A1C's up, weight is up. I'm thinking about these meds. I'm fortunate that I have a pharmacist to help me manage these meds. I'm not worried about them in the obstructed cohorts because there's some safety data that exists, but I am advising patients really make sure when you start these meds, you're doing I'm encouraging PO intake. You're really pushing the fluids.
Absolutely. So what A1C and BMI are you looking for?
Really anything that I would start a diabetes med for. So if they're coming to me and they're 6.8, and I would be thinking about a diabetes med, and they're not on metformin already, which is the other arguable go-to as first line, I'm offering GLP-1. I'll tell you, I'm a little nervous to say this to a national audience, but I have had some success referencing the STEP HFpEF trial and the SELECT trial, which both dealt with GLP-1s in cardiac risk groups, where I, in a nondescript way, say, this is a patient with cardiac comorbidities, and I'm getting non-diabetics approved for semaglutide with some of that coding.
Okay.
Not been universally successful. It's varied by insurance, but I have gotten some non-diabetics GLP-1s.
And BMI for the non-diabetics?
Typically 35 with the comorbidity is what I've seen, but there's big insurance variability right now.
Right. Perfect. Yeah, and totally agree for your obstructives. Increase that PO hydration, particularly during the initiation phases of these medications. Generally, do you see that these the GI motility issues ease off after a little while and those resolve?
Yeah. So if I was kind of just advising general cardiologists about how to get it in the GLP-1 agonist game, I would say start low, go slow. That's the big rule. Is just pick the 0.25 semaglutide dose. Pick the lowest dose of whatever one you want to use and tell them you're not going to feel good on the first day that you take this. The second time you take this, it's likely going to be better, and so on and so forth. Help me by tolerating some of these side effects that I know are going to be yucky. And let's let you plateau at a weight for 4 weeks, 6 weeks before going up. Start low, go slow, warn the patient, push PO. And that's kind of how I'm approaching it.
And again, more time needed in the office visit to discuss this. So probably not visit 1 or 2. You're probably going to tackle this at a later date, but definitely something important to keep in mind. Next, and again, kind of related, is physical inactivity. So I think that our patients, just common theme is that the patients with HCM, there's a delay in diagnosis because they're coming in with these vague chest pain or breathlessness symptoms. So there's a delay in diagnosis. Very similarly, I think there's a delay in time to table for patients who are suffering from inactivity for orthopedic issues. I've seen a lot of patients come in that say, my orthopedic surgeon says I need a knee replacement, but because I have HCM, I'm not a surgical candidate. And I try really hard to work with the other providers and provide education so that we can do everything we can do to get that patient feeling better, whether it's knee, back. This can be an inactive population due to symptoms. They're gaining weight, and that just leads to more orthopedic issues. So how do you go about this, and how do you provide surgical clearance? Specifically, what are you saying in your surgical clearance letters? And how does this differ for obstructive versus non-obstructive, ICD, no ICD?
Absolutely. It's an important area to address. The first thing is I do want to reiterate what you said, and that is HCM patients get in this cycle where they don't feel great working out, they don't feel great exerting themselves, they gain weight, they get out of shape, then they feel even worse when they go back. And so they gain weight, they get out of shape. And so HCM patients, the SHARE registry looked at this, have higher rates of obesity than the general American population, which is a pretty high benchmark to compare yourself to. So it's really important that we address the inactivity. With respect to surgical perioperative risk stratification, sometimes this is really sticky because you're right. Occasionally, the anesthesiologist or surgeon sees HCM and they just assume that means prohibitive risk. What I do in my note is I try and say elevated, but usually optimized cardiac risk, appropriate for surgery with precautions. And what are those precautions I offer? Well, in the obstructed group, I say big IV fluid push before starting surgery, right? Keep them on maintenance fluids before surgery. And I usually explicitly write, not that anesthesia doesn't know this, but just to grab their attention, Should blood pressure support be needed intraoperatively? Encourage use of fluid and phenylephrine as choice of vasoactive agent. Again, anesthesia knows this, but what I want is for someone's attention to be drawn to my note so that rather than parking the obstructive HCM at the end of a hall covered by maybe one of your less experienced providers, that somebody's got some awareness to go, hey, this could get a little bit complicated and we really need to be focusing. This is not someone where I just start norepi at 5 and go, don't worry, I rescued the blood pressure, because that patient can spiral. So in summary, I encourage similar language that I use with other patients, elevated but optimized risk. I give some anticipatory guidance, particularly about latent obstruction. And occasionally, despite all of that, Robin, I'm calling the surgeon. I'm just saying, hey, this is going to be okay. If you want to move it to the main hospital, fine. If you want to contact anesthesia and talk about, do you need cardiac anesthesia, fine. But this is an operable situation.
Do you find that actually picking up the phone and calling the surgeon is also quite helpful in addition to providing the letter of clearance?
When things get sticky, it's usually because something was lost in translation.
Right.
And so ultimately, person-to-person contact usually wins the day. I say usually because I recognize how complicated things get. But for the most part, when you just pick up the phone, I found that helps.
Right. And so you said you're going to optimize them surgically. So if you feel like you have their obstructive symptoms managed, but they're telling you they have chest pain, you might consider some form of stress testing. So maybe this is a good segue into how do we evaluate for coronary artery disease in this patient population?
Absolutely. So the guidelines did not explicitly comment on this, but single photon emission computed tomography, SPECT, our traditional nuclear scan, has a very high rate of false positives in HCM. I really work to avoid SPECT in this patient population. I use a lot of CT heart, CT coronaries. And then when available, I will use PET because PET, mostly out of the Hopkins group, has some good data that supports less frequent false positives in HCM patients. And so I'm not using my stress echo. The sonographer was really focused on the gradient for me. They weren't looking at wall motion, right? I'm not using my stress echo. I'm not using SPECT if I can help it. I'm using CT, particularly in younger cohorts, or PET in somebody with established coronary artery disease.
And I think too, just tackling these modifiable risk factors, getting them on a statin if you see significant calcification. So the CT to me is really my go-to as well. And I just try to use all the information I get from it to optimize the patient from all angles. Yeah, generally I'm staying away from nuclear studies and heavily rely on the CT scan. So I think that we're pretty similar with our practice choice there. Next, HFpEF. So these patients, of course, we're going to modify everything else we have already discussed. Our high blood pressure, targeting HFpEF, first by targeting good blood pressure, but then we can incorporate some of the medications targeted for HFpEF as outlined in the heart failure guidelines, most notably the SGLT2s, the MRAs. How are you incorporating those agents into obstructives versus non-obstructives? And I think probably first and foremost, if it's HFpEF symptoms, make sure it's not obstruction. Number one with our patients all the time is if it's chest pain symptoms, make sure it's not because of obstruction. If you're seeing someone and they're labeled as non-obstructive HCM, but they have chest pain symptoms, they have breathlessness symptoms, before you say it's HFpEF, make sure it's not obstruction. So let's say that we really check that off of the list. How do you go about incorporating these medications into our obstructives and our non-obstructives?
Yeah, I love the framework you laid out there because the tendency to say, oh, this is just non-obstructive HCM is really tempting, right? It's really alluring, but make sure they don't have obstructive coronary disease. Make sure they don't have latent obstruction. Take those things off the table because you're going to be chasing your tail for a long time if this was just a proximal LAD. So once you take those things off the table, you start becoming more convinced this is related to their non-obstructive physiology, I start to, again, subclassify them. So the first one that's probably the hardest for me is there's no coronary artery disease, but the symptoms seem to be mostly chest pain. I'm leaning into antianginals. I'm occasionally considering PET to get a diagnosis of microvascular disease or diminished coronary flow reserve. Occasionally, I'm reaching for ranolazine, but goodness, that means I'm scraping the bottom of the barrel. That's a really tough group that needs some therapies in the pipeline. If they're still having symptoms after that, quite honestly, I'm thinking about aficamten trials. I'm thinking about Edgewise trials. I'm thinking about clinical trials. Sonata would be another one with SGLT2 inhibitors. But let's pretend that's what was not what we were talking about. Second group, which again, I don't think was the one you were referencing, I make sure I understand the exertional symptoms. As you know, Robin, about a quarter of these patients get autonomic dysfunction, and that can be manifest with dropping your blood pressure on exertion, right? That can be from an inability to augment heart rate, right? Maybe related to the beta blocker and calcium channel blocker. So make sure you're not giving a beta blocker and calcium channel blocker that they don't need. And make sure if this is an autonomic dysfunction problem, that you're thinking about things like actually hydration in a non-obstructive group. But I don't think you were really talking about either of those two. I think what you were talking about is elevated filling pressures, non-obstructive HCM. What I'm doing in that group is very similar to what I do with run-of-the-mill HFpEF. I don't have data to support everything I'm doing. And in fact, I would say there's a paucity of data to support what I'm doing. But the agents that I'm thinking about in elevated filling pressure, non-obstructive HCM, MRAs, Marty Marin did a study that showed spironolactone didn't delay fibrosis, but it wasn't really powered to look at things like heart failure endpoints. And so I'm thinking about spironolactone based on TopCat, based on HFpEF literature. I'm thinking about SGLT2s, although a good number of those patients now I'm shifting over to clinical trial because Dr. Day, Charlene Day, is running a trial for SGLT2s in non-obstructive and obstructive cohorts, but I'm thinking about that. I have occasionally reached for Entresto, but now we're talking about a 2B indication for HFpEF that I'm trying to then apply to a totally different patient population that is not obstruction. Man, if I'm getting there, that's again, I'm thinking about clinical trials. And if I'm not in a place that has clinical trials, I'm thinking I might need to get this patient to a place with clinical trials because maybe cardiac myosin inhibitor is the answer here. I also, if the filling pressures are really up, I'm thinking about right heart cath to verify the pressures. And that's something I really got from Dr. Owens, Dr. Anjali Owens at Penn. And then sometimes they need a loop diuretic, right? They've moved past these other HFpEF treatments. So caveat, I don't have a lot of data to support what I just described, but MRAs, SGLT2s, loop when necessary, clinical trial. Don't forget to treat obesity with your GLP-1s. I'm treating them very similar to I treat HFpEF.
And when you're saying clinical trials for these patients, are you saying this because you're having trouble getting maybe the ARNI approved for the 2B indication for treating HFpEF in these patients or for the SGLT2s when you are executing that clinical trial pathway? What is it for? Is it just because of limited data or is it coverage issues?
Excellent question. I have been fortunate that I've not had a lot of pushback for Entresto, though I don't use a ton of it in preserved EF, non-obstructive HCM. MRAs and SGLT2s generally now are pretty easy to get approved as well. Sometimes I code HFpEF, and honestly, it is HFpEF, right? I don't think I'm being untrue when I code that, and for the most part, I'm not getting a lot of pushback. GLP-1s are the area where I'm most likely in a non-diabetic patient going to get pushback. But even that seems to be improving with the major trials from semaglutide.
Mm-hmm. What are in the clinical trials you guys are currently performing for the SGLT2s? What agent is it?
It is, I'm going to butcher the name, sitagliflozin. I apologize. And it's actually an SGLT1/2, so it blocks up the uptake from the gut as well as from the kidney.
And do you notice that that's a little more effective than purely the SGLT2?
I have not noticed that difference. What I would say is, despite Dr. Day's best efforts to explain to me how this might be changing the cardiometabolic profile of HCM, SGLT2s and SGLT1/2s still feel a little magic to me. But every trial they've seemed to have run seems to work in the cardiac space. So I'm not betting against them, even though I don't fully comprehend how it's changing the profile in this subset.
Right. Well, perfect. Well, they are definitely a good go-to for managing your HFpEF symptoms, and very, very comprehensive review of how you're tackling HFpEF. I really appreciate that.
Absolutely.
And we're approaching the end of our time, so it's probably a good time to wrap up here. Thank you so much for your time today. I love your pearls and how you, most particularly, I love your surgical recommendations and how you go about optimizing patients for clearance. And truly, you just have taught me so much too on how you go about HFpEF, and I love your approach. So I really appreciate this. Thank you so much for your time today. And before we go, I did want to give listeners my email address. We like hearing from our listeners, and I want to hear about what topics you guys want to hear more of. So if you like kind of this bread and butter, how do you manage HCM, please feel free to shoot me an email. My email address is Bryder, BRYDER, @slhs.org. So that stands for St. Luke's Health System. Of course, we do have a variety of topics on board. Looking forward to getting something out soon about managing atrial arrhythmias, but definitely want to hear from our audience. And Dr. Ayers, any final thoughts to share with the audience today?
No, what I tell these patients is you're actually much more likely to run into big problems from run-of-the-mill things, run-of-the-mill heart attacks, run-of-the-mill strokes. So you have to help me make sure we're not forgetting your blood pressure, your cholesterol, your diabetes, your weight, your activity levels, even your mood when necessary. We got to be treating all of those things because those are more likely to actually land you in trouble.
Very true. Yes. As these patients begin to live longer, healthier lives, we're starting to manage more of the general things, which is a beautiful thing.
It's a good thing.
Yes. Well, fantastic. Thank you so much again for your time. And we'll see you very shortly.
Absolutely. Thank you so much for having me.
Thank you.
That was Dr. Michael Ayers and Dr. Robin Bride. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.